If you look at an old, like, 15th century map of the world, there are these massive, mysterious blank spaces everywhere.
Right, where the cartographers would just draw um, a sea monster or write, "Here be dragons" over entire continents.
Yeah, exactly. Because they simply had no idea what was actually there.
I mean, the instruments they had at the time just couldn't capture the reality of the landscape. They were really just doing their best with very limited tools.
Right. But when you think about modern medicine, you naturally assume we have this like perfect high definition Google Earth view of every single inch of the human body.
Which is a very common assumption, yeah.
But yet, if you look at the medical history of millions of women experiencing severe chronic pelvic pain, they have essentially been handed one of those old, blurry 15th century maps.
It is an incredibly frustrating reality for patients. I mean, someone will undergo a standard physical exam or, even a traditional 2D ultrasound.
And the doctor just comes back into the room and says, good news, everything looks completely normal.
Exactly, when in reality the patient is in agony. And it's because there is a highly complex hidden topography of submucosal scar tissue and muscle dysfunction that those standard tools simply cannot see.
Well, today we are officially tossing out the old maps. Welcome to the deep dive. We have a really fascinating stack of sources in front of us today. Clinical guidelines, systematic reviews, and some cutting-edge imaging studies.
Really groundbreaking stuff in these papers.
Definitely. And our mission for this deep dive is to understand how specialized technology is finally illuminating this hidden landscape. We are talking specifically about 3D, endovaginal, and transperineal ultrasound.
Yes.
So if you have ever been told your pain is a mystery, or, if you just love seeing how next-level tech solves seemingly impossible anatomical puzzles, you're going to get a lot of clarity today.
We really are looking at a complete paradigm shift here. It's changing how the medical field maps, understands, and ultimately validates chronic pelvic pain. And a big focus in this research is dyspareunia, which is painful intercourse. But to really understand why these new 3D cameras are so revolutionary, we first kind of have to understand the tricky terrain they are trying to photograph.
Okay, so let's unpack this terrain. A major culprit highlighted in all the sources is a condition called deep infiltrating endometriosis, or DIE. Now, a lot of people are generally familiar with regular endometriosis, right? Like tissue similar to the uterine lining growing outside the uterus.
Right, that's the basic mechanism.
But DIE is a very specific, much more aggressive variation.
Yes, so the defining feature of deep infiltrating endometriosis is really the depth. These endometrial implants penetrate deeper than 5 millimeters beneath the peritoneal surface.
And the peritoneal surface is that thin membrane lining the inside of the abdominal cavity.
Exactly. And when they invade that deeply, the body reacts. It creates this rigid fibrotic tissue.
So you can think of it as like incredibly dense submucosal scar tissue.
Spot on. It's super dense. And this tissue frequently infiltrates highly complex anatomical areas. It can wrap around the uterosacral ligaments or actually embed itself into the bowel, the bladder, or the rectovaginal septum.
Which naturally leads to the pain.
Oh, absolutely.
And the studies in our sources make a very deliberate distinction here. They highlight two types of dyspareunia experienced by these patients, deep dyspareunia and superficial dyspareunia.
Right, which are very different mechanisms.
Yeah, so to visualize this, is superficial dyspareunia essentially like having a severely clenched fist? Like if I squeeze my bicep constantly all day, the muscle becomes exhausted, inflamed, and super hypersensitive to any touch.
That is a great way to visualize it.
Is that what's happening at the vaginal entrance?
Yes, it is strongly linked to pelvic floor muscle hypertonia, which just means the muscles at the entrance of the pelvis are in this state of chronic involuntary tension.
Wow, just constantly clenched.
Right. It is actually a protective guarding mechanism the body develops in response to chronic pain. So your clenched fist analogy is perfect for that functional muscular issue.
But then you have the deep pain. And deep dyspareunia isn't a cramp, right? It's more like hitting a physical structural roadblock of scar tissue.
Exactly. Deep dyspareunia is caused by mechanical pressure or traction.
Traction, like pulling.
Yeah, pulling. During intercourse, there is literal pushing and pulling against that rigid fibrotic scar tissue of the DIE lesion deep inside the pelvis.
No.
And that fibrotic tissue doesn't stretch or give way like normal healthy tissue does. So you have two entirely different mechanisms of pain occurring.
A structural roadblock deep inside and a functional muscle cramp at the entrance.
Precisely. And they often occur simultaneously in the exact same patient.
Okay, wait, I want to push back on that logic for just a second.
Sure, go ahead.
If the superficial pain is essentially a giant muscle cramp in the pelvic floor hammock, and the deep pain is traction on the scar tissue, shouldn't relaxing the muscle hammock take the tension off the entire system?
That's a very logical assumption to make.
Right. Like, why doesn't fixing the muscle tension relieve the pressure on the deep scar tissue, too?
Well, it comes down to the microscopic architecture of the deep lesions. The deep fibrotic nodule is structurally fixed. It has physically invaded a rigid space like the wall of the bowel or a ligament.
Oh, I see.
So, relaxing the surrounding hammock of pelvic floor muscles doesn't alter the dense collagen matrix of that 5 mm deep scar tissue. The roadblock remains entirely intact, even if the muscles around it loosen up.
Okay, that makes total sense. The scar tissue is physically anchored in there.
Right. Which explains why a doctor performing a basic exam might just feel the tight muscles, prescribe some muscle relaxers, and then the patient comes back a month later, still in absolute agony from the deep lesions.
Because they only treated the entrance. So how do we actually see and measure a muscle cramp that deep inside the pelvis? I mean, you can't exactly put a blood pressure cuff or a heart rate monitor on it.
No, you can't. And this is where our first specialized imaging modality really comes into play. It's called 3D and 4D transperineal ultrasound, or TPUS.
TPUS.
Yeah, and it's a completely safe, non-invasive technique. The ultrasound transducer is just placed externally on the perineum. But what makes TPUS uniquely suited for this is that it captures dynamic, functional changes in the muscle in real time.
So it's not just a still photograph like an X-ray. It's essentially a live video of the pelvic floor in action.
Yes, exactly like a live video. And the specific metric clinicians measure with this video is called the levator hiatal area, or LHA.
The levator hiatal area?
Right. The levator hiatus is basically the main opening in that hammock of pelvic floor muscles that supports all the pelvic organs.
Okay, got it.
So during the ultrasound, the clinician measures this opening at rest, and then during a maximum voluntary contraction, which is like when you do a Kegel exercise.
Right.
And then finally, during a Valsalva maneuver, which is when the patient bears down.
And when they look at women suffering from this superficial tension pain, what does that live video actually show?
Well, in women with deep infiltrating endometriosis and hypertonia, the levator hiatal area is significantly smaller.
Because it's clenched tight.
Exactly. Because the muscles are so tight and rigid, when the patient tries to bear down or relax, the opening simply doesn't enlarge the way a healthy muscle should.
So it literally gives the doctor objective mathematical proof of a profound inability to relax.
It does. It validates what the patient is feeling.
And that brings us to a really compelling randomized controlled trial in our sources involving pelvic floor physiotherapy.
Oh, this study's fantastic.
Yeah. They took women with DIE and superficial dyspareunia, put them through physical therapy, and used this transperineal ultrasound to track their progress. And the physical therapy actually worked. The patients successfully increased their hiatal area during the Valsalva maneuver. The muscles literally relearned how to relax.
And as that ultrasound metric objectively improved, the patients reported a massive reduction in their superficial dyspareunia.
That is amazing.
Yeah, the median pain scores dropped significantly. It really proved that addressing that clenched fist at the entrance provides very real, measurable relief.
But circling back to my earlier question about the anchored scar tissue, the trial data showed that the physical therapy had zero statistical effect on the deep dyspareunia.
Right.
The deep pain didn't budge at all.
Which perfectly illustrates the limitation of physical therapy. I mean, no amount of biofeedback or muscle stretching is ever going to dissolve a fibrotic nodule that's invading the bowel.
No, of course not.
To solve the deep pain, you have to surgically remove the structural roadblock.
But a surgeon can't just go in blindly based on a patient saying, hey, it hurts deep inside.
Definitely not. They need a map.
Exactly. They need a highly detailed map of where that submucosal scar tissue is hiding. Which leads us to the real heavy hitter in our sources, 3D endovaginal ultrasound.
Or TVUS, as it's sometimes referred to in the literature.
Right, TVUS. Now, the sources note this is fairly easy on the patient. There's no harsh bowel prep, no fasting, just a comfortable volume of urine in the bladder.
Very low barrier to entry for the patient, which is great.
But the terminology in the guidelines gets incredibly dense here. They keep saying it uses volumetric acquisition and multiplanar reconstruction.
It sounds like science fiction.
It really does.
Okay.
Like, let's demystify that for everyone listening. What is the software actually doing with the sound waves?
Okay, let's break it down. A standard 2D ultrasound is basically like taking a single slice of loaf of bread.
Yeah.
You only see what is exactly on that one flat plane.
Just that one slice.
Right. But with 3D volumetric acquisition, the probe sweeps and captures thousands of those slices simultaneously.
Oh, wow.
And then the software stitches them all together to build a solid block of digital data.
So it's almost like the machine is building a virtual 3D clay model of the patient's pelvis right inside the computer.
That is a brilliant way to picture it, actually. And once you have that digital clay model, multiplanar reconstruction just means the clinician can electronically slice through that model in any direction they want on the screen.
Oh, so they can do this long after the patient has gone home.
Exactly. And crucially, it allows them to generate the coronal plane.
And the coronal plane being the view as if you were looking at the person straight on, like face to face?
Yes. And the thing is, a standard 2D vaginal ultrasound physically cannot give you a coronal view because of how the probe is inserted.
Right, the angle is all wrong for that.
Exactly. But the 3D software can render it from the digital volume. In the female pelvis, the coronal view is an absolute game changer. It allows the clinician to map the exact contour of the uterine cavity and closely examine what's called the junctional zone.
The junctional zone, that's that inner border where the lining of the uterus meets the muscular wall, right?
Yes, and it's a prime location for disease to take root. Furthermore, this 3D rendering is incredible for finding lesions hiding in the posterior compartment, particularly in the rectosigmoid colon.
The data on that was pretty wild. It shows that for detecting endometriosis in the rectosigmoid, 3D endovaginal ultrasound has a specificity of 84 to 95%.
Which is extremely high.
Yeah, to put that in human terms, if the ultrasound machine says the scar tissue is there on the bowel, you can be between 84 and 95% confident that it is absolutely there. It's highly reliable.
It is.
But I noticed the sources don't treat ultrasound as the only tool here. They compare it heavily with MRI.
Right, they do.
And they aren't positioned as competitors, like fighting for dominance. The modern surgical approach actually uses them as a tag team.
They absolutely rely on each other. I mean, endovaginal ultrasound is unparalleled for that high-resolution, targeted look at the posterior compartment and the uterus itself.
But it has limits.
Yeah, ultrasound has a limited depth of field. MRI, on the other hand, offers much broader anatomical coverage.
Right, so it can see higher up.
Exactly. It has a higher sensitivity for finding lesions high up on the bladder or way up on the uterosacral ligaments that the ultrasound probe simply cannot reach.
So an expert clinical team uses both the 3D ultrasound and the MRI to assemble this complete topographical map before anyone ever picks up a scalpel.
Precisely.
And the sources emphasize that this map completely dictates the surgical strategy. There is a specific measurement, they keep mentioning, the lesion to anal verge distance.
Yes, a very critical measurement.
They map this down to within 20 millimeters. Why is 20 millimeters so critical?
Because that specific measurement dictates the patient's quality of life after they wake up from surgery.
Wow.
If the imaging shows a fibrotic lesion has infiltrated the wall of the bowel, the surgeon needs to know exactly how low that lesion sits in relation to the anal verge. If it sits high enough, the surgeon can perform what's called a primary anastomosis.
Meaning they cut out the disease section of the bowel and immediately sew the two healthy ends back together.
Correct. But if the imaging map shows the lesion is very low in the pelvis.
Wait, if it's too close to the anal verge, there wouldn't be enough healthy pipe left at the bottom to safely reconnect it, right?
Exactly.
Would the connection leak? Does that mean they have to use a stoma bag?
You've hit the nail on the head. If the distance is too short, the risk of a leak is dangerously high. And in that case, the patient will require a temporary stoma.
Which is a bag on their abdomen to collect waste while the lower bowel heals.
Right, usually over several months. And because 3D imaging can measure this distance so accurately beforehand, the surgical team can bring in a colorectal specialist to assist.
So they aren't caught off guard mid-surgery.
Exactly. And most importantly, they can have an honest conversation with the patient beforehand, so she can mentally prepare for the real possibility of waking up with a stoma.
That is just, it's a huge shift. It's the difference between waking up from surgery to a massive life-altering surprise versus having a fully prepared, multidisciplinary team ready for your exact anatomy.
It is a massive leap forward in patient care.
But this 3D volumetric mapping isn't just for endometriosis, right? The sources show it's being used to find a whole spectrum of hidden submucosal defects that cause pain.
Oh, absolutely. The applications are really broad.
Let's look at introducine adhesions, or IUA.
Sure. So intraduct adhesions are basically fibrous bands of scar tissue that form inside the uterine cavity. They typically develop from damage to the basal layer of the endometrium.
Usually following a surgical procedure like a D&C or a severe infection, right?
Yes, those are the most common causes.
And just to clarify for you listening, the basal layer is the foundational bottom layer of the uterine lining, right? The layer responsible for regenerating the tissue every month.
That's right.
So if that foundational layer gets scraped or infected, it just scars over and creates these fibrous bands that stick together.
That is exactly the mechanism. The walls of the uterus literally stick together.
Yikes. Well, the meta-analysis in our stack of sources gave some really dense statistics on using 3D transvaginal ultrasound to find these hidden bands.
The numbers are very impressive.
Yeah, it cited a pooled sensitivity of 0.86 and a specificity of 0.90. But the part that stood out to me was a tool called a Fagan nomogram.
Ah, the Fagan nomogram, yes.
Let's translate this into plain English. If a woman is sitting in the waiting room experiencing unexplained missed periods and pelvic pain after a past surgery, what do these numbers actually mean for her?
Okay, so a Fagan nomogram is simply a visual tool used to calculate how a test result shifts the probability of disease.
Okay.
To put it in plain English, for that patient in the waiting room, let's say her doctor listens to her symptoms and estimates she has about a 50-50 chance of having intrauterine adhesions.
A coin toss.
Right. But if the doctor performs a 3D endovaginal ultrasound and the test comes back positive, that nomogram proves her actual probability of having those hidden bands just jumped up to 88%.
Wow, so it takes the guesswork completely out of the diagnosis.
It does, and it prevents her from having to undergo a diagnostic hysteroscopy just to figure out what's wrong.
Which is an invasive surgical procedure where they put a camera inside the uterus, right?
Exactly. The 3D ultrasound confirms it non-invasively.
That's incredible.
And the technology is also proving invaluable for mapping cesarean scar defects, which are known clinically as ismosceles.
Right, and ismocele is basically a structural indentation or like a niche left behind in the muscular wall of the uterus at the exact site of a previous C-section scar.
Correct.
And apparently, the newer 3D ultrasound software uses a feature called Realistic View for this. How does that work?
So Realistic View is a rendering algorithm. The software actually simulates a virtual light source inside that digital clay model we talked about earlier.
Wait, like shining a digital flashlight inside the scan?
Exactly like that. By directing this virtual light, it creates shadows and depth perception that mimic real physical structures. It allows the clinician to measure the exact depth, width, and volume of that C-section pothole in the myometrium.
The myometrium being the muscular wall of the uterus?
Yes.
And knowing the exact depth of that niche would dictate whether the patient needs medication or another surgery to repair the uterine wall.
Right. It completely guides the treatment plan.
But I want to slow down for a second here because there was one application in these sources that honestly just stopped me in my tracks.
Yeah. Which one?
Using 3D endovaginal ultrasound to map occult tears in the levator muscle.
Oh, yes. The levator avulsions.
The statistics on this are staggering. The sources say up to 33% of females experience an avulsion or a tear in this major pelvic floor muscle during their first vaginal delivery.
It's an incredibly high rate of injury.
1 in 3 women. And yet, the sources state it goes completely unnoticed in a standard physical exam. How is it physically possible that 1 in 3 women tear a major pelvic muscle during childbirth and a doctor's manual exam just misses it entirely?
It sounds impossible, I know. But it makes sense once you understand the anatomy of the injury.
Okay, walk me through it.
So an avulsion means the muscle has literally torn away from its attachment to the pubic bone deep inside the pelvis. But the crucial detail here is that the vaginal mucosa, the skin and surface tissue overlying the muscle, usually remains completely intact.
Oh, so it tears underneath the skin, but the skin itself doesn't break.
Exactly. So when a doctor performs a manual exam after delivery, everything feels smooth and normal on the surface. The catastrophic structural failure is completely hidden beneath the mucosa.
That is just profound. So a woman goes home, she's in chronic pain, she's experiencing dysfunction. Maybe years later, she develops pelvic organ prolapse or severe incontinence.
And she's frequently told by doctors that her exam is normal, and it's just, a natural part of aging after childbirth.
That is so infuriating.
It is. For decades, those women were entirely dismissed. But high-resolution 3D endovaginal ultrasound has changed that completely.
Because it can see beneath the surface.
Yes. It has actually replaced MRI as the research gold standard for some of these conditions because it can generate that digital volume, slice through the intact surface tissue, and physically show the doctor and the patient the detached muscle. It is also used to precisely map the location of synthetic vaginal meshes that were previously implanted and might have shifted, which can also cause severe, unexplained chronic pain.
Going back to where we started this whole conversation, this shift from relying on subjective physical touch to objective, volumetric 3D imaging represents an unbelievable leap in validating women's pain.
It really does.
I mean, if a patient is in agony and the doctor feels nothing with their hands, that old dynamic meant the doctor assumed the pain was psychological. Now they can render a 3D map and say, no, it is not in your head. Your muscle is detached from the bone. Or there is a 5 millimeter fibrotic lesion embedded in your uterosacral ligament.
It is the ultimate vindication for these patients. It gives a very real voice to the pain that was previously invisible.
Let's quickly recap the journey we've taken through these sources today. We started by exploring the complex terrain of pelvic pain, distinguishing between the deep structural roadblocks caused by the rigid scar tissue of endometriosis.
Right, the D-die-E lesions.
And the superficial tension headache-style muscle cramps. We saw how 3D transperineal ultrasound can dynamically record that muscle tension, proving that physical therapy can successfully teach the pelvic hammock to relax and relieve that superficial pain.
But we also learned that physical therapy cannot dissolve deep submucosal scar tissue.
Exactly. For that, we saw how 3D endovaginal ultrasound and MRI work together as this amazing tag team.
Yes, using volumetric acquisition and multiplanar reconstruction to map the hidden fibrotic tissue.
Plotting the exact distance of lesions to the anal verge so surgeons know whether to prepare for a simple reconnection or, a temporary stoma.
Right.
And finally, we saw this incredible 3D technology applied to a broader map of pelvic trauma, using tools like Realistic View to detect hidden intrauterine adhesions, measure the depth of C-section defects, and finally locate those undetected devastating muscle tears from childbirth.
The scope of what we can now see is just amazing.
So for you listening, whether you are trying to understand your own anatomy to advocate for yourself in a doctor's office, or you're prepping for a medical career, or you are just deeply curious about how technology solves human mysteries, you now know that chronic pelvic pain doesn't have to be a permanent blank space on the map.
Not anymore, no.
It is a very real physical landscape that simply requires the right 3D camera to navigate and treat.
And as we look to the future of that navigation, I want to leave you with one final thought to explore on your own.
Let's hear it.
We have seen how advanced 3D imaging can definitively map microscopic fibrotic tissue and hidden tears that were dismissed for decades.
Right.
Right? Well, imagine what happens when we eventually train advanced artificial intelligence on millions of these 3D volumetric data sets.
Oh, wow.
Yeah. How might the future integration of AI with these imaging modalities completely revolutionize a doctor's ability to instantly diagnose, map, and finally validate chronic pain syndromes, not just in the pelvis, but across the entire human body?
Now, that is a map worth exploring.